Dr. Michael Miller. I'm the CEO and Medical Director of the Miller Care Group, a multi-specialty practice in Indianapolis, Indiana. My own practice for the last 20 years has been wound care. In my practice, we see a lot of different kinds of chronic and acute wounds, but we see a considerable amount of diabetic neuropathic ulcers. Today, I'd like to take a few minutes to talk to you about the gold standard for treating diabetic neuropathic ulcers, namely total contact casting. In our practice, we use the M-Med Mobility Series Total Contact Casting kit, and the reason for this is because of the multi-adaptability, the multifunctionality of the kit. It's a multi-component system. You recognize that each patient is different, and of course each diabetic neuropathic ulcer on any given patient is different. You certainly wouldn't apply the same treatment to a 300-pound linebacker as you would to a 98-pound grandmother. And so the particular kits that we use from M-Med tend to allow for adaptability. They're multi-component. They have several different sizes of fiberglass. They have different padding that can be added or removed or changed to allow the kit to be configured to match your patient. Total contact casting, as I said, is the gold standard for treatment of diabetic neuropathic ulcers. The entire process, of course, involves a good workup, establishing the vascular status of your patient, making sure that they have not just good micro as well as macrovascular status. Other things are nutrition, of course controlling their blood sugars, and most importantly, patient compliance. Once you've established all of these, or at least confirmed that you've got a good candidate, one that has the highest potential to heal, the next step then is to prepare your patient. In a diabetic neuropathic ulcer, the key is to make sure that the ulcer itself is ready to heal. This involves a process called debridement. There are many different kinds of debridement, but for diabetic neuropathic ulcers, the most efficacious is sharp debridement. In our practice, we use a 5mm curette, though a scalpel blade is certainly equally efficacious. The key is to use your sharp debridement to take away the entire surface of the diabetic neuropathic ulcer's base, including the skin margins. Basically, we recommend that at the conclusion of your debridement, there should be 100% bleeding from the entire diabetic neuropathic ulcer surface. This assures that you have a healthy, acute diabetic neuropathic ulcer surface, something that's healthy and most importantly, ready to heal. Once you've identified a suitable dressing, the next step then is, of course, to prepare to apply your total contact cast. The M-Med kits come with a polyurethane foam that you'll see us apply in a few moments, and that's what they include in the kit. It's easy to apply, it's simple, it's inert, it absorbs. Of course, if you feel that you want to use another kind of dressing, a specialty dressing, stem cell dressing, another organic or bioorganic dressing, perfectly acceptable, because the gold standard for treatment of diabetic neuropathic ulcers is offloading, and that's the goal of the M-Med Total Contact Casting systems. The patient that we're going to apply the total contact cast on today is a middle-aged type 2 diabetic who's had a diabetic neuropathic ulcer of the distal plantar surface of his foot for several months. We have previously debrided the ulcer to 100% bleeding several days ago, and because of some minor post-op bleeding, elected to apply a compression dressing, allow for hemostasis, and we brought him back today for definitive application of the total contact cast. It's important to recognize that while it is certainly possible and appropriate to do your debridement and plan for the application of a total contact cast at the same office visit, you need to be sure that you have achieved true hemostasis before you apply your total contact cast. The initial part of the application of a total contact cast for a diabetic neuropathic ulcer, after, of course, a very, very good and complete debridement, is the application of the polyurethane foam pad. It's a fairly simple process. You apply the pad, you apply the tape, and the kits come with a roll of paper tape. So it's a fairly simple process to apply. Make sure it's reasonably well centered over the wound, and then apply the tape. And the first part's done. In diabetics, there's a tendency to have xerosis, or very, very dry skin. And so as you can see in this patient, we took the liberty of applying a little bit of skin cream to the areas that will be exposed. The toes, of course, we try not to put it where the tape and the foam pad is, and of course the rest of the foot up to and including the areas that are going to be encompassed by the total contact cast. Once you've done that, the next is to apply the stockinette. And the stockinette is applied simply by rolling it up and basically applying it over the foot, making sure that your foam pad doesn't change position, and then you gently move it up. And again, to a position, we tend to go about the mid-widest part of the calf muscle with the stockinette, because the cast itself should only go to the mid-inferior portion of the calf. You're basically thinking in terms of a piston in a chamber, and once you get the widest part of the calf down into the total contact cast, that contributes to your offloading, and subsequently there's no need to go any higher with the cast. For cosmetic reasons, of course, we'll then roll the cloth top of the stockinette down just because it tends to look a lot nicer. Any extra stockinette can be cut off, and then the next thing we do is, to prevent it from bunching, we apply a small piece of the enclosed paper tape over just to hold that securely. The next step is to apply the anterior adhesive tibial pad. This is component 3 in the kits. And what we do is we go to an area on the anterior tibia and we roughly measure. You don't need this to go down to the toes, and in fact there's going to be plenty of padding in this area, but you do want to cover the areas that don't have a lot of protection, especially in the form of subcutaneous fat. And so we apply this about a centimeter or two below the highest point we intend to put the cast, and then of course down over the ankle. At this point we then cut it off. The excess is handed off. The key to doing this, you'll notice that the back of the anterior tibial pad has 3 lines in it to separate the adhesive. We recommend you take off the middle one and then take off the lateral sides. If you try to take it all off, there's a possibility that you will separate the adhesive layer from the cotton, and of course that makes it difficult to apply. You can see there is a little bit of separation here. That's inconsequential. We then again apply this over the anterior tibia, because this is how you're going to protect your bone and of course the anterior. We want to make sure that the foot's at 90 degrees or as close as we can to 90 degrees, and we'll talk about some changes in that angulation a little bit later. But right now, the part where we apply the protective anterior tibial pad is complete. Medial and lateral malleoli, and of course these pads are specially configured. Similar situation where you gently peel the paper off and the adhesive backing, and you apply it over the lateral malleolus. And we tend to apply this with the flat part straight toward the front, and of course on the medial side, similar application. Gentle press and the adhesive holds very well. The beauty of having excess amounts of the anterior tibial pad, and you can see we have about 6 to 8 inches or so of it, is we can then, if we need to, and in this case it's my preference, to protect the 5th metatarsal and also the 1st metatarsal. So what we do is we tend to take that, cut it lengthwise, and then by removing the adhesive, we then apply this on the lateral surface here, and we apply it on the lateral surface or medial surface as well. This doesn't change the offloading dynamics, but it adds a little bit extra padding to the lateral and medial aspect of the foot. The next step is we then have these additional protective pads. Since part of the process of total contact casting involves, of course, the removal, you want to do so in a safe manner. And so what we tend to do is take these additional protective foam pads and we apply these medial and lateral to the anterior tibia pad. What this does is it protects the leg from any possible damage from the saw blade, and it adds a little bit more padding along the lateral and medial aspects of the tibia. At this point, we have a fairly well protected tibia and leg structures, so when we remove the cast, it can be done in a safe manner, and of course a little extra padding underneath the total contact cast never hurts. The next component to apply is of course the cotton padding. What this does, it tends to smooth out any of the lumps or bumps and allows for a much smoother application of the next supportive layers, the fiberglass for example. The way we tend to do this is very simple. Much as in any other roll application, we tend to start at the top of the foot, and again, there's no way to apply pressure, and you just gently roll in about a 50% overlap pattern. We tend to continue the overlap all the way down, making sure that our pads are secure and they don't move. Our technique is to go behind the heel, leave only a small area, and then re-catch that as we come back around. Of course, you want to try and make sure you've got plenty of padding on that anterior ankle-foot junction, since that's where most of your problems can happen. And we apply it all the way up to the top. We have a second roll, and of course, the beauty of this is that we then apply this. And since we've gauged our height, basically what we'll do is we'll start at the top, and that defines our proximal most point of the total contact cast, and then come back down in a 50% layer. You of course can continue up from the bottom, doesn't matter, as long as you're getting plenty of padding on these areas to protect them. The toes we're not going to worry about right now because we have a piece coming that'll take care of any kind of pressure or friction and protect that area as well. The next component to add is the Seafoam adhesive pad. This is the part that's going to protect our toes. Similar removal, you have the piece of paper with the adhesive, and again, a simple removal exposes. We then tend to apply it so that we have a little bit of a ballooning around the toes. Foot's going to shift a little bit in the cast, and so leaving about a centimeter or so space between the distal pad and the toes is what we recommend. And then again, it's a simple process to just compress the foam down. Now you've got the toes protected, your foot is well encompassed. Once it's done, you then want to cut off the corners because it's much easier to apply your fiberglass to a rounded area than, of course, a square area. So we'll trim these off a little bit and give ourselves a nice, smooth, rounded distal pad on the toes. Next component, and the first of the fiberglass layers that you apply, is the 3-inch fiberglass layer. And of course, this is applied in standard fashion. Basically, the fiberglass is wet, and we recommend you hold it in for a second or two. The other thing to remember is that the water should be cold. Hot water increases the chemical reaction and will hasten the hardening. So, the way we apply this is we start at the toes, we go around to the back, and I do this in 2 layers. This provides my initial protection for the toes. Once we get behind the heel for the second point, we then come up at the anterior ankle, go back and catch the heel, and then progress the wrap forward with a 50% overlap. Now you notice that we've got the toes covered. We'll move slowly forward, making sure that the Seafoam pad is attached. And then we want to make sure that we have a fairly nice and a fairly complete. And if we have something like this where we don't have it covered, we'll come back around. And again, the key is to have a complete seal and everything covered by your initial layer of fiberglass. The next thing we tend to do is progress backwards with whatever's left and start working our way back up the leg. There's no need to get all the way up the leg with the first roll. I think it's more important to get your total contact cast distally set. And again, we'll set this, and then making sure it's not wrinkled, and then layer 3 is applied. The next layer we apply is the 4-inch layer, and that's your second layer. Once again, moisten it by inserting it in cool to cold water. A few seconds, shake off the excess, and then again, once again, we tend to take it, we do 2 around the toes. overlap, a little floppiness, not a problem, especially with 2 layers. And then again, we go back, we catch the heel, making sure that we've got that. We then, because the key to this is to make sure you have a secure planter surface so that you can put your gasket underneath, since that's what the patient is going to be putting their weight on, and that's what contributes to the offloading. And once again, we've got that. It's a fairly smooth appearance, no wrinkles. Once we're done, of course, with this being a 4-inch, we can now go a little bit farther up, and we'll do so. We'll take it all the way up as high as we can go with this layer. The next step is to have the patient create the flat surface to put the gasket. M-Med uses a flat board, preferably non-adherent, and what we'll do is we'll place this board on the floor, and then we have the patient stand on it for a few seconds until the cast hardens. We ask the patient to stand in the normal position, forward in their standard weight bearing. So come a little farther forward. Lift your foot up 1 second. Good. Now, just stand. Come forward. Good. So the patient is now in a 90-degree neutral position. We make sure that the cast is hardening well, and you have them hold this position until you get fairly reasonable hardening of the cast. Again, the goal is to create a flat surface to apply your supporting gasket and allow the patient to ambulate. At this point in the process, we now have a flat surface to put our disc and our rubber walking gasket on. The anterior toes are now well protected, but if you look proximally, we still have a little bit of support to create. So what we tend to do here is we'll create this. We start the 4-inch layer up here, and we've established the highest part. At this point, we then roll down our cloth. Create a nice cosmetic appearance for the cast. And then we'll continue down, again, in about a 50% overlap. Just to add a little bit more support. And reinforce the flat bottom of the cast. Again, no need to redo the toes. And once you're at the top, allow this to harden for a few seconds. The next step is to apply the foot end plate and the rubber gasket at the bottom, and this is what the patient's going to be walking on. If you remember that the bottom of this cast is a single unit and spreads the pressure out over the entire bottom of the foot, as opposed to point pressure, which is how these ulcers develop, then this should be placed in an area about mid-portion where you would expect the patient to be walking. So what we do is we set it about mid-foot, and then we hold the gasket here. We tend to apply this fairly quickly, and of course what we do is we roll this. We turn it into a rope, and the first place I apply it is at the mid-portion of the gasket. And again, we find our position, and then it's held in place. Once we have that, then we do the same thing. The gasket's held securely, and again, turn it into a rope, because that provides a lot more volume over a shorter area for support. Remember, you're going to have patients walking on these, and so the more support you can, the stronger you can secure this to the plantar cast, the better. And again, fairly snug, you pull it back, and then if you want, which we recommend, to kind of smooth it out because you've got exposed surfaces, then you go with a more flat approach. And we like to put 2 or 3 layers, kind of a upside down V configuration, making sure that the cast is there. And then again, another one anteriorly. We do this until basically you run out of the cast material. For support, we'll tend to roll it again, maybe one more layer in the middle. This is all your individual choice. And then again, up over the top. If you have any extra cast material, you're worried that you're going to wind up at the bottom. Nothing wrong with cutting off the excess. And then it's just a matter of smoothing out your cast, making sure that your gasket's in good position, because you have a few seconds anyhow to do so. Things are smooth, things are nice, your cast has a good cosmetic appearance. You'll note that up here we are at the level of where the calf starts to expand, so our position is pretty good. And at that point, your total contact cast is done.
That is odd.
Yeah, I see. It allows you to walk as much as you want. However, psychologically, it's inconvenient because it's a little bit offy. So patients tend to say, you know what, I'm a little unsteady. I don't want to walk too much. So it's psychologically, it keeps people from walking too much.